With the permission of Chair, Joint Secretary Madam, I welcome all of you for the National Orientation on Revised NSSK and NBSU training modules. Respected Joint Secretary Madam, Additional Commissioner Madam, Mission Directors, expert panelists, State Child Health Nodal Officers, District RCH Officers, Master Trainers of NSSK and FBNC training modules, representative from training institutes, doctors, nursing staff, representative from professional bodies, development partners, academicians, focal points from Regional Resource Center, National Collaborative Centers, Child Health and Maternal Health team, and all participants who joined us through this virtual platform and YouTube platform. Each and every one of us are an important pillar in India's journey to reduce newborn deaths and to our commitment to ensure every newborn is able to survive, thrive, and transform into a productive citizen of our country. To begin today's deliberation, I am honored to invite Dr. Sumita Ghosh, Madam. Madam is Additional Commissioner at Ministry of Health and Family Welfare and in charge of Child Health, Adolescent Health, RBSK, Comprehensive Abortion Care, and Aspirational District Program. Over to you, Madam Sumita Ghosh. Please, Madam.
Thank you, Dr. Kapil. I welcome you all for this important web meeting now. And a very good afternoon to all of you. I think almost 900 of us are here today, joining us on this platform. As you are all aware, that during National Newborn Week, November 2020, Hon'ble Union Minister of Health has released revised NSSK guideline and a new NBSU training modules. NSSK trainings are being held since 2011 and it needed some revision. We have 20,000 newborn care corners all over the country where this training will be immensely useful. We have established more than 2,500 NBSU, Newborn Stabilization Units across the country, but there was no structured training for this till date. So today we are here for orientation on these newly released training modules and for further rollout. The structure of today's webinar will be like this. We begin with introductory session and keynote address by our chair, JSRCH, Madam Preeti Pant, followed by one session from Dr. Siddharth Ramji on global and national situation of our newborns. Following this session, we'll have 4 technical sessions on training methodology and rollout plan of NSSK and NBSU trainings and our expectations from various partners, our development partners and professional bodies, and that will be followed by vote of thanks. I would request to comply with certain housekeeping rules because we have such a big, huge gathering online here. We have a packed agenda. I request all the speakers and experts to follow the time allocated to them. All participants will be on mute with videos off to allow least distractions and during presentation and peaceful hearing. For any query, please post your comments on the chat box where our group of experts will be responding to you immediately or in a time frame. It will be responded to. Any of your colleague participants, if they face any kind of logging in, because already many have logged in, so YouTube link will be shared in the chat box. So please join in that. To begin with today's deliberation of the introductory session, I am honored to invite Madam Preeti Pant, Joint Secretary RCH, to provide her guidance and share her vision on newborn health in India with the participants. Since December 2020, Preeti Pant Madam has been heading and guiding us in the RCH division of MOHFW, and she has a passion to strengthen our public health system for improving quality of care. Welcome you, ma'am. Please be there for the presentation, for your talk.
Thank you so much, Dr. Ghosh. Okay, so I'm not able to do my video, so if you want, you can do it later. So I'm very happy to note and to know that we are joined with more than 700 participants, for this very important National Orientation on Revised NSSK and NBSU training modules. I would say that Dr. Ghosh is very passionate about her, importance and about issue of importance of the child health, that is the center stage. And so we are very happy to, though it is a bit delayed that we are having this orientation, because the revised guidelines were issued somewhere in the newborn week in somewhere in November 2020. But as we all are aware about this ongoing COVID pandemic, so it took us some time to organize this orientation. But we are very happy from part of the ministry to know that there are nodal officers, technical experts, service providers, representatives of development partners, and other professional bodies who have joined this this orientation workshop. So you all are aware that we are committed to accelerate the reduction in newborn deaths by more than half by the year 2030 under the newborn action plan. And if you see that newborn health is a very important pivot, rather it is the driving pivot on both of adolescent health and maternal health. Because if you have a healthy child, a child that survives, the woman will need not go again to the reproductive cycle. So it is we should always keep that in our focus. The child health, often we tend to just take it as a because the child has been born, the lady has safely delivered. So we start presuming that the child health will also automatically follow. But that may not be the case. We would require more focus, more attentions to ensure that our child is born, our child is saved. And so as to continue the reduction in the number of neonatal deaths that India has witnessed from 13.5 lakhs, which were earlier in 1990s, to 6 lakhs in 2018, as I'm given to shown by the statistics shared with me by our program division lead, Dr. Ghosh. And we all are aware that this ongoing COVID pandemic has made it all the more difficult, and all the more reiterate our commitment towards the importance that is to be attached as regards newborn care services. And timely care around birth and appropriate facility-based care is very important for the survival of the sick and newborn child, as you all are aware. And quality is another important aspect. And Dr. Ghosh, I would also request you to share with this audience that we are also coming up with the quality initiative and quality parameters for SNCU facility, which we are trying to develop together in consultation with the NHSRC. So as to further, just like we are doing Laksh for the OTs, we are also coming up with a quality programs for these SNCUs and other facility-based care around newborn care. And so, as it was said in the beginning, that this NSSK and NBSU packages were released in November 2020. And today, we are going to have a detailed discussion. You would hear from experts, various experts, which includes Dr. Ramji and Dr. Navjat and among others, to name a few. And we will see that what is the kind of action plan that we are supposed to have. And I'm sure this will help in the service providers in improving the skills for rendering essential services for newborn. So I would be very happy, and I would urge each one of you to please take part, give your suggestions, give your inputs, give your guidance. Please participate actively so as we come up with a robust plan, so as to we try to factor in the aspects that we may think need our attention and which need to be built in our rollout methodology. So, and I would also request the partners and the collaborating centers who are who have joined us, including NNF, IAP, FOXY, WHO, UNICEF, NEP, Save the Children, USA, JPIGO, etc. All of you. So, welcome to all of you, and I hope we have a very fruitful discussion for the remaining part of the afternoon. Thank you all. Dr. Ghosh, I hand over back to you. Thank you.
Thank you, madam. Thank you for being there, for your guidance and bringing newborn health to the fore and giving it a pivotal status. And that is really that will motivate our participants. I would like to tell you, ma'am, for your information that previous to this, we have had big discussions with the big states, five states of them, to have their rollout plan, how like to suggest ways, and also what is the present status, how we can go about it. And we had again discussion with all our development partners, like what should be the ideal way for rollout. Thank you, madam, for giving this renewed zeal towards this. I would like to now call our technical expert, Dr. Siddharth Ramji, who is a Director Professor for Pediatrics and former Dean of Maulana Azad Medical College. Dr. Ramji, having experience of more than 4 decades in pediatrics and neonatology, has chaired and been associated with several committees at different levels, and he is a very renowned clinician and president-elect for National Neonatology Forum for coming year. And he is very closely associated with all ministry programs on newborn health. So for this session on the status and current situation, international and global, in view of NSSK and NBSU, I over the floor to you, sir, Dr. Ramji.
Thank you, Dr. Ghosh. You can hear me? I hope so. Yeah. So we are not visible, but I think Madam Pant actually set the context quite clearly as to why we are all assembled today. And I will only like to add on as to why it's so important, particularly with regard to these 2 new packages. NSSK is not new. We had it, but we have had to revamp it for make it more skill oriented, so that competence is important. And the second is the NBSU. As Dr. Ghosh said, we did not have a separate package. It was assumed that the SNCU package will take care of it, but over time we realized that the challenges of NBSU are different, and so this is the reason why we have this, and it's an unmet need which we are trying to fulfill. Can I move to the next slide? Can roll down? Yeah. So let's begin. We have a commitment. The Sustainable Development Goal is the basis of a lot of activities that is going on now. SDG 3.2, which is particularly related to neonatal deaths, you will realize that the global commitment is to bring it to less than 12 neonatal deaths per 1,000. But India has been very ambitious. We want to do better. We want to bring it to single digits and say it should be less than 10. Stillbirths is another issue. I just want to flag the issue that SDG doesn't talk about stillbirths, but stillbirths is a very important part of maternal health. And it has been included as part of the global strategy for women, children, adolescent health. And the commitments on the and on the part of the WHO is very similar to keep it less than 12 per 1,000 births. India, of course, has a commitment which is just similar to its own neonatal commitment of bringing it down to less than 10. So we need to see where are we vis-a-vis these targets. Can I have the next slide, please? Can you just roll? Yeah. So when you look at neonatal deaths, the red line clearly says where we would be if we were to continue at the current annual reduction rates. And if you can see, if you are at 2030, you would be not in single digits. You'll still be above the global numbers at something like 15 or 16. But what we need to do is to deviate and start accelerating, just like what the yellow line says, so that's where we need to go. So we have maybe a little less than 10 years to move very quickly, almost 10 points, which is coming to an average of maybe 0.9 to 1 points per year if we want to achieve our target. So please remember, all of you, that in order to achieve that, we have to do many things. And one of them is what you're going to discuss this afternoon. Next slide, please. Stillbirths. Unfortunately, the stillbirth reductions haven't been so well seen as we see for the neonatal reductions, but we really have to bend this very, very steeply. And I will share with you as to how these packages done today will contribute to what else we are doing in terms of fetal survival. So just please keep these two figures in mind, these two graphs in mind, that we have a very, very a race, but time is premium. We don't have the time. So we really have to accelerate a lot of our interventions if we have to get this targets and ensure adequate coverage. Next. Can you go to the next slide, please? Yeah. So we all know the cause of neonatal deaths. Just to remind ourselves that more than half the deaths are due to two major conditions. One is birth asphyxia, which has its origins sometime during labor, most often. And of course, for many mothers, it's also related to their own way their health has been taken care of during pregnancy. And of course, we have low birth weight in preterms, which is a major contributor. Of course, preterms don't die directly due to preterm, but there are many problems peculiar to preterm. And that is where institutional care is so vital. So please remember that if we want to bring a reduction in our neonatal mortality, we have to make sure that asphyxial burden decreases, and also the burden of deaths due to small babies also decreases. And if you want to reduce stillbirths, many babies who don't breathe at birth are declared stillbirths without even offering them a chance of resuscitation. And so it's very clear for us that if you look at NSSK, we are mandated to ensure that all non-macerated births, which are born with no breathing or poor breathing, should all be offered resuscitation, and that will contribute in some ways to the reduction of deaths due to birth asphyxia. Next. So basically, therefore, if we want to look at reduction of these two major components of neonatal deaths, care around birth is critical, and care for small and sick newborns is critical, which means that every newborn must have access to these cares, just as we want every woman to have access to reproductive health and pregnancy care. And as Madam Pant said, challenges of reduction of child mortality is different. So we also want every child eventually to get hold of all the postnatal care and other care that's needed during childhood. So our focus today is to look at care around birth and ensure care for the small and sick babies. Next one. Can you move the next slide, please?
Sir, we are not able to hear you. I think we are disconnected with Siddharth Ramji sir. Ramji sir, are you able to hear us?
There is no audio.
Phone karo.
I'm audible? Yeah. Okay.
Yes,
you are
yes, sir.
audible.
Now you are.
Yeah, thank you. So if you look at what is going to work for us, clearly, if you look at the second bar, and look at the blue arrow, which is related to stillbirths, NSSK will have a major role here. And similarly, NSSK will also have a major role in reduction of deaths at this time to newborns. So NSSK has a very great potential of making a huge reduction. And you can see this is one of the largest bars that will contribute to the lives saved. And then if you look at the small babies, it's very clear that you need institutional care. And so the last column that's there, which is where our SNCUs are contributing. But as I'll show you later, we have a large potential in the NBSUs, which we are not tapping, which we should, so that we are able to
The differential. Next.
object. Can you go to the next slide? So where are we currently? As Dr. Ghosh said, we have close to 700 plus SNCUs in the country, which are offering at the district level. We also have some tertiary level, 195, some of them in medical colleges. They contribute to almost 12 lakh annual admissions sometime in 2019. That's the last data we have. And we have NBSUs, as she said, little over 2,500, which admits about 3 lakhs. And a quick back of the envelope estimates show that we actually, most of our SNCUs are oversubscribed. We have 100% or maybe more. But when you look at the NBSUs, we are only using 1/4 of the capacity. And we do realize two things. Number one, that a lot of small babies who are born are not so very sick that they need to be in SNCUs. They need some warmth, they need some feeding, they need some glucose monitoring. And NBSUs are great places for them to be there so that our SNCUs are not overcrowded. Our NBSUs currently, because of the overcrowding, has the following problems. One, we are not able to afford the optimal care that we should be giving. So it tampers with quality. And two, it also, there's, my understanding is when you look at data, it may also be contributing to some people leaving earlier, what we more popularly call LAMA, earlier than required, because there is either it's too crowded or the SNCUs are too far away from their place of residence, and NBSUs would be less crowded, closer to home. And it's possible that if we offload some of this to our NBSUs and make them vibrant functional units, we shall be able to survive, let more kids survive. I think this is something that we need to keep at the back of our mind. Next. So how do we fill this gap? If you want to reach the, India has committed the following coverage targets by 2030. We want 95% of all the babies who should be getting resuscitation should get resuscitation. That means nearly most of them who are entitled to get resuscitation should get it, which means it's not only the newborn corners, not the SNCUs, but also NBSU. So every delivery point should have people who have the capacity to resuscitate babies. And that is where our NSSK fits in. Currently, data that we have from our SNCUs are maybe 15 to 17% of our babies getting admitted are due to birth asphyxia. And I think close to 20% are those who are very severely asphyxiated, what we more popularly call as HIE or encephalopathy. The problem is that if you do not effectively resuscitate these babies in the first few minutes of life, even if they survive, we will be handing to this country a huge burden of children who have developmental problems. And as most of you will know, to have a developmentally or challenged child in a family has huge repercussions beyond the health sector. It affects the social dynamics of the family. It has huge economic impacts on the family. And those of us who are experienced either to treat or even have a family member with a child with development delay, you can imagine what it costs to transport a child from home to a center for his treatment. So I think the task for us is really prevent this. And so NSSK has been remodeled in a way that will build competency, and you hear more about it during the course of this afternoon. NBSU, as I said, now needs to fill in the gap. we are talking about 90% of our low birth weight and preterm should be managed, especially with KMC. We are also aware that in our SNCUs, probably because of the large workload, the nurses have to do many more things. The extent of KMC that we would like to achieve has kind of taken a slight hit. So if they work in places like NBSU where they're not so crowded, mothers are there, mothers are the primary caretakers, in fact, in NBSU, as you'll see, I think we will also achieve the care that we want of 90% care for low birth and preterm, including KMC. The third part, which I would like to draw your attention to, is the fact that we have done very well over the years with our SNCUs. More babies are surviving. That's creditable. But when we look at our follow-up unfortunately is abysmally very poor. There are many factors, but I think one of the factors is also distance. People, as I said, find it very hard to travel long distances, and particularly in times like this, like COVID, then even more of a bigger problem. And if you want the 70% SNCU discharge follow-up to happen, I think it's very important that there must be facilities like the NBSU, which become the hub for follow-up of such children, so that we can pick up problems related either to the growth or related to the vision or hearing or whatever it may be, so that they can be identified early and, if required, sent to higher center for further rehabilitation, or else the physician there is competent to provide the necessary inputs for improving. So please understand that while we have facility-based newborn, which we've been doing for a long time, I think the top two, NSSK and NBSU, are very critical in order to fill the gap that we currently have, and they have immense health systems implications. Can I next slide? And finally, just a word, since this is related to our rollout and planning, I think we need to be very careful that identify the designated and trained facilitators, because these are all competency-based training sessions. We don't want them to be simple classroom sessions. We want that all the parts, end of the day, have these skills. Two, I think we need to also ensure that the people we select are those who are going to go back to these facilities and use these skills at the workplace. And of course, we have to make sure that the supplies and equipment, boarding, lodging, all of them are made so that the trainings go well. And I think it would be only two other things. We should not stop with training. Training has to translate into actual practice, which means there shall be how we'll monitor and record, which should be discussed today. And finally, I think what Madam Pant said, quality. End of the day, I think India has now gone past a stage where survival is not the only issue. For us, the quality of survival, we have now reached a point where quality of survival is very important for India, with increasing newborn surviving. And so at any cost, I think we now must move the agenda forward. And all of us must make it our mission to ensure that whatever we do is done with quality. We must believe that these women and children are our own family, and we should do exactly what I expect for our own family members, with no separate standards. We should eventually ensure that each one of our citizens in this country gets the quality of care. At the end of the day, please remember, if we do not have a good outcome, it also has great impact on human capital. We have lots of data to show that children who don't grow well actually become low productive citizens. And I don't think India would like to have a situation where we have, because of a population which starts with a handicap, should contribute to its economic downfall. I'll stop at this, Dr. Ghosh, and hand it back to you. Thank you.
Thank you, sir. It's always our pleasure to hear from you today in a very simple words to describe us about what is needed and what will work in this current situation to achieve our neonatal targets and of our neonatal mortality. Dear friends, we all know about NSSK. Many of us are master trainer or trained in NSSK. But a common question all can have, that why we revise this NSSK? What is the new in this revised package? What is the training methodology? Is there any change? To get these answers, I'm inviting Dr. Susma Nangia. She is head of the Department of Neonatology at Lady Hardinge Medical College, Kalavati Sharan Hospital, having over 3 decades of experience as a teacher and clinician. She is co-convener of National Collaborative Centers for Facility-Based Newborn Care and former Vice President of Neonatology Forum. Dr. Susma Nangia, Madam, please, over to you, Madam.
Thank you, Kapil. And I thank our Joint Secretary, our Additional Commissioner, Madam, and all the people in the division, Child Health Division. So we will talk about NSSK. Thank you, Professor Ramji, for setting the stage and for letting us know what are the gaps over there and how to go about filling those gaps. So am I audible, Kapil?
You are clearly audible.
Yes, yes.
Please share it. Go ahead, madam.
So we will talk about the Navjat Sishu Suraksha Karyakaram 2020. As you can see, there are 2 visuals seen. One is the flip chart that will be used, and the other is the manual which will be used by the trainers to. So this is actually the resource manual on the screen on the right side. On the left side is the flip chart, which will be used for the training. Can I have the next slide? Yeah. So all of us baby who is lustily crying right at birth, but there are situations, and most of us know that about 10% of these babies will require some help, and that is what we are going to learn in NSSK. So NSSK, the Navjat Shishu Suraksha Karyakaram, was rolled out by the Government of India in the year 2009-10, so about a decade back. And the whole idea was that service provider should be skilled in the basic skills to ensure there should be hypothermia, which is prevented, not treated. Of course, if it is there, it will be treated eventually, but prevent hypothermia, establish effective respiration, prevent infections, and establish early and exclusive breastfeeding. So what we know is that about 1.5 lakh health personnel across the country have been trained till now. But what was the expectation and what is the anticipated success? The anticipated success was that in all these places, wherever births are occurring, the babies will be resuscitated. But the results were contrary to our expectations, and hence the need to revise. Next, please. So this NSSK training was evaluated, and this training assessed the gaps in the existing methodology. Were there any gaps? And why we did not achieve the desired results despite a decade of these trainings. Okay, so the recommendations of the evaluation were that we must select appropriate trainees, by which we mean people who are going to be there at the time of birth and who are going to handle the newborn there. Prioritize the training as per need. If there are new providers who have joined, they should be trained. If the existing ones have suboptimal skills on assessment, they need to undergo retraining. If there is high caseload facility, or if there is high turnover or high attrition, then the new ones have to be trained. So this needs to be taken care. Adequate number of dedicated trainers should be available. Well-equipped training sites. So if you don't have the required infrastructure, and if you don't have the training sites which are well-equipped, then the trainings cannot be going on the way they should be going on. We need to have training aids available, which includes some of the disposable equipment and some of the disposable consumables, along with the mannequins which are required. Then there should be demonstration of the skills right there, and hands-on practice should be there. There should be regular updates and refresher trainings. Next, please. So the current NSSK package has been customized to address these recommendations. So this package now has no didactic sessions or classroom presentations. There is actually no reading material for the participants. There's a flip chart, which is for visual facilitation, which promotes participatory interaction with better retention of the concepts by the trainees. Optimum facilitator to participant ratio, which is 1:6. So for 6 participants, there's 1 facilitator, which ensures there is standardized training. There is individual attention to each participant, which ensures uniform skill transfer. The quality of training is maintained, and there is hands-on practice of the skills that is taught right there and then, rather than having the skills at the end of the day. Next, please. So the logistics for each group of participants, as you see here, you can see everything in terms of 4: mannequins, stethoscope, self-inflating bag, mask, and so on and so forth. All the things that are required for resuscitation to occur, and similarly for resuscitation training to be accomplished. So these are 4 in quantity each, so that each table or each station has the whole logistics. Okay, the details of the training. Who could be the facilitators? So let's say who should be the trainees. The trainees should be those who are doctors, nurses, ANMs, who are positioned at the delivery points at sub-centers, PHC, CHC, district hospital, medical college. So those people who are positioned at the delivery points, and they are directly involved in providing the essential newborn care. So who could be the facilitators? You could have facilitators as nurses from the medical colleges, the SNCUs, or IANN faculty, which is the Indian Association of Neonatal Nurses, faculty from there, faculty from nursing colleges, faculty from A&M training centers, skill labs, and Dakshta program. Training site could be at the district hospital, high caseload sub-district facility also could serve as a training site, skill lab, of course, and A&M training centers. Duration is 2 days, a little less than 2 days, but okay, almost 2 days. Batch size, 24 participants with 6 facilitators. With 4 facilitators, so a batch size of 6 per facilitator. We could increase it to 7, so not more than 28 participants for a training with 4 trainers. And what is the training package including? It includes the flip chart, which I showed in the beginning, a wall chart, which has not been shown, which will be stuck to the wall, and people will move to the wall in between to revise till where have we reached in the algorithm of resuscitation. And there is a resource manual, which is for the facilitator. The resource manual is for the facilitator, not for the participant. So let's go through the agenda quickly. The agenda will be on day 1, neonatal resuscitation algorithm will be taught after the initial registration and inauguration, etc. So which will be for 75 minutes, where we are only talking about how to prepare the delivery room, how to prepare the equipment, and they are discussing it right there, and they are also organizing a small place with the equipment as a delivery room. So this is done side by side as the flip chart training goes. Post tea break, then we get into the routine care, and if a baby does not cry, then what should be done in terms of initial steps. Bag and mask is initiated here, and thereafter the training continues, ventilation corrective steps and other things that are taught. So the resuscitation is taught on day 1. Can we go to the next one? On the day 2 is the recap of day 1, which was resuscitation till bag and mask, and thereafter is the postnatal care in the delivery room and thereafter in the postnatal ward. So care after birth, after the first hour of birth, wherein we mean that during the first hour, the baby should be in skin to skin care, and only after that would be the rest of the things done. I would just show some pictures subsequently. Then is the discharge and follow-up and neonatal transport. If the baby is asphyxiated and cannot remain at the NBCC and has to be transferred up, then transport is also a part of this. Only 2 equipment, that is radiant warmer and bag and mask, are demonstrated, which are in rotation in the 2 batches. Next, please. Okay, so as we are going through, we realize we have a flip chart, we have wall charts, we have the mannequin right at the table, on the table, resuscitation equipment and other supplies, resource manual for facilitators. Next. Okay. So just to reiterate, the healthcare providers who are conducting deliveries and attending deliveries, caring for newborns in the postnatal ward, and attending newborn emergencies are our true participants who should be trained. Next. The facilitators we've already talked about, but the facilitators for the TOT, the initial ones should be pediatricians or trained medical officers or IANN tutors. They will demonstrate on the anatomic models, which is our mannequin. So there is more humanistic approach. Ensure that the participants practice the relevant skills there and then on the table before we move on to the next step. Next, please. Training methods, discussion using the flip chart and the wall chart, skill practice on the mannequin in sync with the flip chart. So it is not after the aspect has been trained and then you go for skill practice is right along with the flip chart teaching at that moment. Equipment demonstration, role plays. So there is essentially, and I'm reiterating that, there is no reading for the participants. Next. So the content key aspects that are covered is preparation for receiving a baby in the labor room or OT, delivery with dignity, hand washing, room temperature is maintained, and what all you require for resuscitation has to be displayed there on the table, and the participants organize that and show that, okay, this is all the preparation that I would require. Next. Routine care, if the baby is breathing at birth, the first question that is asked, then routine care should be provided to the baby. Next. If the baby is not breathing and requires resuscitation, then the initial steps are provided. If required, positive pressure ventilation with bag and mask. And if the baby improves after initial steps or after just the first 30 seconds of positive pressure ventilation, then the baby can very well come back to the mother for observational care. And you can see the last picture where the baby is in skin to skin back again with the mother. Next. Only after the first hour of routine care, that is the skin to skin care, the baby should be weighed, should be given vitamin K injection, and thereafter should be observed. So for the first hour, the baby should not, mother-baby duo should not be disturbed for these routine tasks which are to be done. Next. In the postnatal ward, post-birth, healthy baby, breastfeeding, kangaroo mother care, as you can see here. Next, please. And then vaccination, you can see the BCG being given in the top panel, and discharge and follow-up where you're talking to the family regarding discharge. And when they come for follow-up, the patient is being seen. Next. If a baby who has suffered asphyxia has received resuscitation, needs to be transferred, then referral and transport needs to be organized, which is a key aspect which is covered in the NSSK manual. Next. Okay. Hands-on practice, what all would they do? They would learn how to receive the baby in a dry, warm linen, how to clamp the cord after a minute, how to provide routine care, how to provide initial steps if required. Next. Resuscitation using bag and mask will be practiced by every participant, each participant, till they get the chest rise correctly, till they are able to do bag and mask for 30 seconds. Monitoring, technique of kangaroo mother care, technique of breastfeeding. Next. The equipment, as I said earlier, two equipments. One is self-inflating bag and mask, where how to disassemble, how to reassemble, how to clean it, all those aspects will be taught. And of course, what size bag, what size mask, and radiant warmer, its functioning, any troubleshooting, that would be taken care during the equipment demonstration. Next. So the way forward actually, ma'am is going to tell us. So basically, we need to do state level TOTs to develop resource pool of trainers, and mentoring needs to be done by our existing FBNC or NSSK trainers. I think that's all related to the resuscitation, NSSK, and you could see the algorithm there. Thank you, Kapil, and over to ma'am, Dr. Ghosh. Thank you.
Thank you, Madam Sushma Navjat. It was really a good session from your end, and you have clearly said that what is the methodology and what all the changes we have made in the NSSK package. Now, for discussing the rollout plan of the NSSK training, I would like to request Additional Commissioner and in charge, Dr. Sumita Ghosh, Madam. Madam is constantly guiding us and encouraging us to put our 100% efforts for saving the lives of our newborn from the preventable causes. Over to you, Madam, Dr. Sumita Ghosh.
Thank you, Kapil. So all the participants, the very details about NSSK training has been explained. What are the difference, what has been the need, and how it is more hands-on, how it is more like density, the proportion of trainer and participants. We have tried to make it lesser, so that the individual attention is given to them. So now comes how do we roll it out. The manuals are there, everything has been, whatever are the logistics, whatever are the training methodologies, everything is written in the manual. So it will come as a very handy tool for the trainers. We plan actually 5 regional TOTs. For giving, for being in contact with the trainers and master trainers and giving them the real hands-on experience. But as we all know, COVID situation permitting, we might have to, we can go ahead with it, or we have to maybe make some adjustments in it. So in that 5 regional TOTs, we'll again have a chance to explain things better and, physically explaining all the nitty-gritties. Since the state NHM persons are here, we have our district level officers, we have our child health nodal, we have many other participants here. So this is the best time we discuss the NSSK training rollout. So first we have to have an institutional mechanism. This training is going on and there are already some established mechanisms. So take advantage of that. Each state has to identify a nodal unit, centers, training institutes, EPIC center who will actually like SIHFW or state nodal newborn resource center will actually coordinate and monitor the training all over the states, which is very essential. And training institutes already have been said that training institutes have to be identified, and we have to have everything in place. It has already been adequately emphasized that what are the resource materials. It has to be, very resource incentive. You have to have the logistic in place. So a good planning is a must for having a good quality NSSK trainings henceforth. Have the training plan in place. First thing is to have a fair idea about the training load and what is our actual target denominators, and how do we address and how we plan to cover the whole the universe of load. Then we have to have a training calendar, and we have to have that in a synchronized training manner for whichever are already functional NBCCs and which new NBCCs. So we have to have a training calendar to have in place properly who is to be trained when. Then there is a good idea if we can combine trainings, because we know we expect that all persons who are involved in newborn care, they all be trained in NSSK training. So whenever NBSU trainings are happening for NBSU personnel, we can combine it. So see the feasibility, how, if someone is getting trained in NBSU, how the NSSK training also is combined with it. There is also a suggestion from states, and we think it is quite feasible. We may include the newborn screening training of RBSK, which is actually a very simple handbook-based training. We can have it with the NSSK training so that we can have the birth defects also. So having the training sites and logistics, already told that district level training sites which are already there, they should be made well equipped and hands-on for hands-on skilling. Conduct an assessment of these training sites and find the gaps and do the filling of those gaps so that they are ready to take the new NSSK training. Have the logistics in place. So this was detailed out what are the things which are needed during the training, the flip charts, the training resources, the job aids, everything should be printed beforehand. And another thing is the translation part of it, which we can think of beforehand, and we can use the you can have the help of our partners and other organizations so that we have a translated thing. Procurement of mannequins, wherever the gaps are, do that. Equipments, then translation already told with our partners, we can do that. Then it was already told you have to prioritize, because there is a huge training load, so we have to prioritize districts. So how do you prioritize? You have to see which are the districts with high mortality, especially districts which need rapid transformation, like aspirational district, districts or places which are not covered, and also facilities which have high load facilities. So this way you have to prioritize districts and trainees, and those trainees should be given a priority. Plan for a large pool of trainers. Already trained staff are there, doctors, nurses, NMs. The list was already told by Dr. Nangia. So have them in place. Also do a training need assessment so that if there is any gap, if they need some kind of fresh training, wherever feasible, they should be given a refresher. NSSK rollout, previous slide. Before that? Anyway, leave it. So have the trainers and mentors, because as always already said, that the training will be hands-on and they might need some hand-holding after that. So mentoring visits are to be there, and you'll have a pool of master trainers required from each cadre of doctors, nurses, mentors, teaching faculty from various A&M, GNM training schools. Beside the specialist, we have this pool ready to train and mentor. Mentoring plan has to be there, post-training mentoring plan, how this will be rolled out, which are the facilities, which are the trainees who need mentoring, and they should be mentored through various mentor pools, and they should be brought out from nurses and development partners and our professional organizations who are ready to help us in mentoring. Best to have them associated with some SNCU or district medical college for the mentoring action. Then quality of training, you have to ensure that training which is being imparted, they are done by skilled trainers. You have to assess the skill of trainers, and you have to assess the sites where they are being trained, and you have to assess the training which is being given. Observers are a good idea. Independent observers should be there, and you should have post-training in enhancement of skill by OSCE checklist. So that is very important, and objective and standardized clinical examination should be taken to see how the training hands-on training has actually improved their skill. Now, this link will be provided in your NBSU manual. So this is in all. My request is that do the planning very well, make the training, quality training, and have a plan for monitoring and mentoring afterwards. So this way, if we plan beforehand, our trainings are going to be in a, it can be rolled out in a very organized and successful manner.
Thanks a lot, madam. Thanks a lot. I am just repeating your words. You are always telling us and our team that half work is done if we plan well. So now I am requesting Dr. Siddharth Ramji sir to kindly give us quick comments on this NSSK training methodology and rollout plan. Sir, please.
Thank you, Kapil. I think I just want to reiterate just 2 or 3 very important things. Most often after trainings, we forget what our trainees do. I think this is what Dr. Ghosh very clearly said, that there has to be continuous mentoring of our trainees who are at all delivery points to ensure that the skills are intact. You may have to refresh some of them who are already been trained, but as part of training, we also need to make allowance for the fact that there will be some attrition, or let's say people who leave the system and new people come in. So while we continue with the existing numbers, we must also make allowance for planning for those who are new entrants into the system who will need this. So this is, I think, very important, because we can just on paper, all of us will say we have trained so many people, but it should not be that in 2030 we turn around and say that why has my birth asphyxia rates not come down, and that will eventually be a result of the quality. So I wish to again reiterate what Madam Pant also said, what Dr. Ghosh said, that we should continuously monitor. And so as when we look at the planning, I would like all our state and district level personnel who are involved in this planning to make allowance for the fact that there has to be methods to monitor, record competencies, and in fact, I would even say, if possible, at least in places which have a fairly reasonable and which have moderate to low delivery loads, they must have something on which the staff can keep practicing themselves. So we must have some kind of an area where they can travel down and say improve their skills. So think about it, that somewhere where voluntarily staff can go and get themselves refurbished on their own, even if they don't need it formally. So I think these are the few things that I think we should keep in the back of mind when we do the rest of the training. Thank you, Kapil.
Thank you, Ramji sir. Now for the next session on NBSU training methodology, I am requesting Dr. Sushma Nangia. Madam, please, over to you.
Yeah. Thank you, Dr. Kapil. Thank you, ma'am, for the wonderful rollout plan which has been shown by you. And thank you, Ramji sir, for your comments on the attrition and how we need to ensure that people are there who are, trained people are there who are attending these births. And with that, we will move on to the next one, which is the Newborn Stabilization Unit training, the participant manual or the module that has been prepared. And as you know, that was released on the 20th of November, 2020. Can I have the next slide, Dr. Kapil? Okay, so the facility-based newborn care operational guidelines 10 years back, 2011, envisaged a level care system, and where the levels were 3 levels. The first level where all the births occur, newborn care corner. The next, newborn stabilization unit at the level of CHC, FRU, sub-district level, and the SNCUs at the district level, and up thereafter, even the medical colleges or apex institutions. So this was the care that was envisaged for small and sick newborns at 3 different areas. So at the newborn care corner, it's basically immediate care after birth and referral of those who are at risk or who are sick and small. Stabilization unit, as the name suggests, was for stabilizing the newborns who are presenting with emergency signs, and thereafter referral to the SNCU, and management of some of the sick and small newborns which meet the inclusion criteria, the admission criteria for the NBSU, to be admitted there and trained there. So this is a facility which is an inpatient facility, and obviously SNCU, most of you know, for comprehensive newborn care, everything to be done for sick and small newborns except for ventilatory support and surgery. This sub-district level newborn care, this plays a critical role towards improving the overall newborn outcomes, because currently the babies will move from birthing place right to SNCU if he requires an admission, which is at the district level. So this will also help decongest the SNCUs at the district level in terms of admitting some of the babies who meet the admission criteria. So also some of the back referrals from the SNCU. Next, please. NBSU, as we all know, has been something which is a weak link. The current situation, as was told to you by ma'am in the beginning and also Dr. Ramji, that there are about 3,300 FRUs, but only nearly 2,500 or 2,600 NBSUs which are there. But hold it there, these NBSUs are present, but they are woefully underutilized because we don't have staff there, it is inadequate, or the staff is untrained. Hence, it is translating into suboptimal quality of care. And the reason is there is no formal training package till now. So they are not being trained for this purpose specifically. Mentoring obviously has been inadequate. Recording, reporting, monitoring, everything has been suboptimal, because this has been the weak link where we have not focused as much as we should have. And rightly so, now we are having the focus on the NBSU. Next, please. So our actionable points really are: prioritize those FRUs which have something in the name of existing NBSU. And these existing NBSUs need to be operationalized as soon as we can do it. The state has to ask for staff support in the PIP. Now we have the NBSU training package. NSSK training package, as we just heard a little while back, has been revised and updated. We also have uniform recording and reporting tool in the FBNC, the online tool, and mentoring support. We need to organize from different places as to how these units would be mentored and who would mentor them. Next, please. So the training package is actually the need of the hour, as I said, and this has been developed keeping in mind the newborn care services that need to be provided at the FRU level. So what is required at this FRU level or at the sub-district level? You need to provide immediate pre-referral emergency care, because as you would understand, the sickest of the baby can be brought to the nearest facility, and which could be an NBSU or which could be a FRU. So pre-referral emergency care needs to be provided, only then the baby has to be referred. We all understand if the baby is extremely sick, he has emergency signs, he will probably not make it till the SNCU. So this pre-referral care is very important. Baby has to be stabilized, as the name suggests. Care after birth for all the healthy babies who are taking birth there and have not required any resuscitation. Management of babies who are admitted in the NBSU. Obviously, they are managed closer to home if they can be, and then they are discharged from there, followed up. This will help, as I said earlier, to decongest the SNCUs, both by referral of these babies to the SNCU if required, and back referral when they have improved, but they are still not ready for discharge. So they can be brought back and they can be managed at the NBSU level. Next, please. So the training package envisages pre-referral stabilization, as you can see in the picture on the right, where the baby is receiving some oxygen. Referral, as you can see, the ambulance and the mother taking the baby. Care of the healthy babies after birth, breastfeeding, kangaroo mother care, care of babies admitted in the NBSU, and discharge and follow-up, where the babies are being followed up, as you can see, anthropometry and some other aspects of examination. Next, please. So the training logistics really are that the trainees or the participants are both the doctors and the nurses who are positioned at the FRU, CHC, NBSUs. Trainers or facilitators are teaching faculty from the Department of Pediatrics in the nearby medical colleges, as also the pediatricians who've been working at the SNCU and they have the experience that they understand newborn care, they are managing babies for some time. They can also be there as facilitators, and designated FBNC trainers who are already there for SNCU training can also be the trainers for NBSU, provided all these category of people have time to invest at the sub-district level and train the doctors and nurses. Training site could be an SNCU or a state or divisional newborn resource center at the medical college, skill lab in the state, or functional state institute of health and family welfare. Duration of the training is 3 days. Again, the batch size is 24 to 28 participants. The ideology remains the same, that you have facilitator to trainee ratio of 1:6, at most 7. Training package includes the participant module, which the participant receives. He reads it during the training and then he takes it home. A facilitator guide for the facilitator and instructional videos that have been prepared. Here, there was one question in the chat box that do we have provision to conduct NBSU and NSSK trainings together? Well, states have the option to do that, and they can include NSSK along with NBSU if they can spare the people for that much time, and or if they want to do it as 2 separate trainings, one after the other. Next, please. Next, please. So the methodology really involves classroom teaching, as you can see. The lower bottom on the right side, a classroom teaching going on where the participants are reading the manual, and you have facilitators there, 2 facilitators for 12 participants in one teaching hall. During this, there are role plays, there are drills which are done, skill stations at the that are being conducted, then bedside clinical teaching, and learning by watching some of the videos. We are sorry we could not incorporate the video to be shown here. We very much wanted to show a small video clip, but I'll just finish by saying that we have prepared 10 videos for this training. There are a list of 10 videos. So infection prevention, technique of hand hygiene, estimation of blood glucose, manual expression of breast milk, feeding that by orogastric tube or by Paladay, intravenous access, how to obtain that, oxygen therapy, kangaroo mother care, and use of pulse oximeter. So these are all the videos that have been prepared. These are very small clips, about 2-3 minutes or so, and they are the ones which are to be shown during the training in between. So when we do the pilots, the initial pilots, we will really know the timeline as to where these videos fit, but they have been prepared. And we wished that we could show it today, but somehow it was not feasible logistically. Next, please, Kapil. So training package, as I said, this is the participant manual. Pre-referral stabilization is discussed there, where how do you assess a baby for emergency signs and how do you manage that baby? And after you manage the emergency signs, how do you refer these babies, the communication with the family, the communication with the receiving hospital, and how do you actually transport them in the ambulance? Then care of the babies who are admitted with you at the NBSU, which includes supportive care for babies, management of jaundice, sepsis, we will go through as we look at the agenda. Care after birth, postnatal care of the babies in the health facility, follow-up, and NBSU stationery and formats for uniform recording and reporting have been prepared. Skill stations have been added for the participants to learn and how to learn and then practice those required skills. Next, please. So agenda for the 3 days goes in this manner. Day 1 agenda is assessment of the emergency signs in terms of temperature, airway, breathing, circulation, and so on and so forth, and management of these, management of severe hypothermia, apnea, respiratory distress, and so on and so forth. For all the emergency signs, how do they assess them and manage them? And the methodology would be that they read the module, there is group discussion in between, there are drills, there are role plays and videos which are shown. Afternoon for the first day has skill stations related to neonatal resuscitation, which they may have learned earlier. So this is just trying to reinforce those skills of resuscitation on the first day afternoon. Can we go to the next slide? Day 2 agenda is referral transport and communication. That is the chapter 2. Chapter 3, assessment for admission in the NBSU, the babies that you're going to admit there and treat there. And chapter 4 is for all those babies that you are admitting at the NBSU, how do you provide supportive care, which is how do you maintain their temperature, how do you decide for fluids, feeding, monitoring these babies, and family participatory care is very important. Parents, mothers are allowed inside, and then discharge planning before we actually end up discharging them. By and large, the methodology remains the same that you see on the right panel. In addition, there is referral note writing, which is specific to referral and transport. So the skill stations in the afternoon are for 3 hours, 45 minutes each. So 4 groups, which are small groups of 6 participants each, or maybe 7. Kangaroo mother care, breastfeeding and expression of breast milk, assisted feeding using Palada, Katori spoon, or OG feeding, video on disinfection of equipment, housekeeping protocols, and hand washing drills. These are the things which would be done here in these skill stations. Next, please. Day 3 agenda is on management of babies who are admitted. So specifically management of jaundice, management of sepsis. The methodology remains more or less similar as to what all is used for transferring the knowledge and skill of the regarding jaundice and sepsis. Afterwards is the clinical session, which is for 3 hours again, 45 minutes each, and participants are divided into 4 groups of 6 participants each. One batch goes to the postnatal ward, other batch goes to the SNCU, because as you would remember, the training is being done either at the SNCU or it is being done at the SIHFW, etc. In that case, during the tea break, after the tea break, they are transferred to the hospital or to the SNCU if the training is occurring at a place which is not right there in the SNCU. Anyway, so the participants go to postnatal ward, SNCU, and then they are going to 2 more stations. One station deals with usage of pulse oximetry, phototherapy, radiant warmer, and oxygen concentrator. And the last group is being taught how to use a glucometer, how to provide IV, IM injections, and how do you collect samples for certain investigations that are required for treating or managing a baby with sepsis or with jaundice. So these 4 groups rotate every 45 minutes. So in the next 3 hours, these clinical sessions are conducted. And thereafter, post-lunch is the recording reporting systems and the operational aspects which are to be discussed by the state health authorities, and discussion on the operational aspects, distribution of certificates, and the other formalities. Next, please. So you have the training package mentoring checklist, which is, as you can see, the link that is provided, and checklist can be downloaded from there. Next, please. There is a facilitator guide which has the agenda of the training for the facilitator to know how to conduct the training. detailed outline of the various sessions, methodology on delivering the course content in a standardized way so that we don't have variation based on individual facilitators. So there is standardized way of delivering that, and role play scripts are available along with the method of conducting the role play or how to run the video. So this all may require a little bit of tweaking after we have done the pilot to see how much time which session takes. Next, please. So skill stations, practical sessions, demonstrate and teach the specific skills, each participants to practice individually or in pairs. Next, please. Enabling environment, this is for our people who are going to organize the training to ensure that we have a common hall for plenary sessions in the beginning of the training and later on. Thereafter, when the actual technical sessions are happening, these are 2 separate rooms with 12 participants and 2 facilitators, 4 separate practice areas with sufficient space for about 8 to 10 persons, which means the participant and the facilitator to stand around with audiovisual requirement. There should be there should be adequate light. There should be no barriers, no noise or distraction. AV system, whiteboard, markers, flip charts, wall charts, videos, and equipment to run these videos should be made available so that the training is conducted appropriately and there are no barriers or issues related to how to conduct the training. Hand washing and dining area for the participants, washrooms for participants as well as for faculty should be there, and they should be maintained clean so that the training can be conducted appropriately. Next, please. Training in charge. We must have adequate space, the relevant supplies that are required, and the equipment that's required. Boarding, lodging for the participants and facilitators trained, and we must have facilitators who are themselves trained. I would like to reiterate that we are all professors and seniors, but it would be good to undergo the methodology of the training, not because there's something to learn, but to understand only this much information has to be transferred to those participants rather than telling them much more than what they require. So it's a good idea to have the facilitators who have gone through this training. That would be important. We should have transport to be able to transport the participants to the hospital for the postnatal ward and the SNCU skills at the last day. And district RCH officer or facility in charge, they must seek support of each other or liaison with each other so that they ensure that the NBSU training has been conducted optimally. I think next one, I think that's all. Yeah, thank you very much. And we will look at the questions. And over to ma'am for the rollout of NBSU. Thank you very much.
Thank you, Dr. Sushma. Now for the next session, which is rollout plan for NBSU training, recording, reporting of NSSK and NBSU, and expectation from our development partners and professional bodies. May I request Dr. Sumita Ghosh, madam. Madam, please, over to you.
Thank you. The NBSU package is new. So whatever was there for NSSK, that may be revamped, but for NBSU, again, you have to have a very fresh planning and have clear objectives and clear targets in mind. Here, again, institutional mechanism will be very important. The already existing mechanism, which is responsible for the FBNC training, because that can be utilized because NBSU training and FBNC trainings are already JOSNCU trainings which are happening. They are very closely aligned. So state divisional, next slide though. State divisional newborn care resource centers, they should lead the training, they should coordinate, and they should monitor the training. About trainers and mentors, the existing pool of FBNC trainers and mentors, they may be primarily involved. For NBSU also with orientation, as Dr. Nangia said, that they are all very good trainers and they are often, they have the skill and expertise, but they have to be oriented how much is to be given for NBSU training. Here, the training sites, next. Training sites, the SNSU should be designated training should be close to the training center because the visits are to be made, and regional, divisional, district resource centers or facilities will be preferred. One thing I want to stress here that the sites will need the training infrastructure because videos are there, so audio visual has to be there. For hands-on training, SNSU and ward visits are to be organized, skill stations have to be there. So all these things should be taken into consideration when we decide upon which should be the training sites. Then training of trainers will be important because this is a new training. So plan for how many state TOTs will be needed or regional TOTs will be needed for creating a pool of trainers, and from the already existing pools we can select them or we can have new ones trained. Next. Quality of training, yes, again, it is very important and observers have to be there from our partners or professional associations who can monitor the quality of training. The procurement of training resources, there are a number of resources which will be needed, equipments like mannequins, charts, modules, videos, all these have to be there. So plan and budget for sufficient sets. And again, as was already pointed out, that many NBSUs are there which are hardly functional. So you have to do a real gap assessment and how this, who all need to be trained and how they are going to be trained. So that training plan, training calendar, synchronized way, in a synchronized way, so that the functional sites, they also get trained and non-functional sites also get trained, and how they will be after training, how they will be placed, where their deployment, all these things are very important for NBSU training because many things are already not there. So you have to be very careful about that. Then NBSUs are to be monitored so that they have to present that they have the presence of trained staff, and data again is we are not getting data from many of the NBSUs, and we really don't know what status is there, what delivery load they are actually catering to. So what we have done, we already the SNSU online software, we are incorporated that so that can be recorded there itself. And review of data, like SNSU data reviews are being done. So same way NBSU data can also be done in that from that software. Mentoring plan, follow a quarterly mentoring plan, and the existing mentoring process is already on for the SNSU. So have leverage that system and have the skill checklist and provided with the training packages for scoring the skills. The data coordinators, the FBNC data coordinators may be utilized for regular on-site mentoring, data and related to records and data updation. That is very important because that is a big, huge gap there from NBSUs, the data part. So have that, and our regional coordinators will train this so that the NBSU data is properly updated. Recording and reporting of NSSK training, maintain training records in already existing system wherever you are doing, or the state TMIS, Training Management Information System. Many states it is there. Many states it is functional, many states it is partly functional, and many states have not yet taken it. So my request to the state persons will be that please use this management information system, which is very good, and any other, if you have like Manav Sampada, Manav Sampada, that can also be used. But we need the data of training because we are starting afresh. So have a full training management information with you and with us to be shared with us. The state should maintain the list of master trainers and have them updated every month or quarter. Then state should also share training status at the national level. We would like to know how this is going. And we are thinking of other mechanisms, how in which the training update can be regularly shared with us. For NBSU trainings, again, list of master trainers, very important. Maintain list of active trainers, update every month or quarter, and add to pool if and when availability declines. We already have a pool of master trainers for ABNC training, and from that data, from that pool, we can add to it. For the trainees, again, TMIs and digital records of service providers trained and place of posting under ABNC portal must be maintained so that we know the functionality of each NBSU sites. Now, I am very happy that our development partners are here today, and they are very interested in having this rollout of trainings because it is a team, it is a coordinated, collaborative actions without which it is not possible to roll out such big training plan. So I would request my partners and the professional bodies which are present there, and I'm very happy to say we have here IAP, FOXY, as well as NNF representatives here. And from the list, I am not able to see participation list, but I do believe the heads are already there. And this is a very good opportunity for us where we work as a team in the public as well as the private sector. And the perinatal team, because the child is a healthy child is outcome of a healthy pregnancy. So the role of the obstetric society, the role of neonatology professionals and the pediatric professionals, they all are very important for us. And we do want them to take active role as, the roles will be that support the state teams in planning and identification of master trainers, and translation of resources. I would request development partners for this, especially in their respective states. Support and conduct training of master trainers. Yes, that is very important for us. What is most important, as already told by Dr. Ramji and Nangia, that we have to have post-training mentoring, because as time passes, there is training loss. Naturally, people get certain loss of training, so that mentoring part is very important as a post-training follow-up. And we need to have a pool of mentors, which must be through our professional organizations and development partners. Quality of training, again, big role our partners and professional bodies can play as observer, and they giving their suggestions, giving the hand-holding to the states for improving the quality of trainings. Conduct gap assessment where required, like there will be, because though our efforts are on from our side, there will be certain gaps in the training side, in the trainer or trainees. So we have to assess that, and the state health mission, the development partners, they can conduct that gap assessment together and fill that gaps and propose accordingly to us. The reviews, again, we would like to have regular reviews and mid-course corrections if needed. So we'd request our partners and other professional bodies to help us with that. And the recording, reporting, without data, we don't go anywhere. So again, there is a big role that the state's hand-holding has to be done through our partners, so that we facilitate our system of recording and reporting. So next slide. So immediate next steps, if I can summarize, organize a meeting of stakeholders throughout the state, and the list of master trainers is to be updated and made up to date. State resource centers should assess the gap supports and prepare clinical sites and provide gap support to address any deficiencies like skills lab, etc. And mentoring part you have to look into, and the state has to calculate the training load immediately. It is the way forward, because without that proper trainings, a number of trainings, number of master trainers, number of sessions, all this need to be planned depending on the load. Prioritize already has been stressed. Next. Prioritize trainees who, when and how early, that has to be previously planned, and the state has the flexibility, but always see that when we plan, you try to give the max so that the system gets the maximum benefit. The areas which need strengthening, the districts which need strengthening, the facilities which need strengthening, the new entrants, the old people who have been trained long back, they should be prioritized also. So that way you prioritize your trainings, have a training and mentoring plan already I have said, and the budget for it, have the financial matters in mind, so that how it is to be done. Budget it in your PIPs, and many states have already done it, and have already said post NPCC you must propose for NBSU, which is a new training. And supplementary PHP is also there, will be also there. You can propose that if you have already not done it present budget. And start planning for mentoring, which is very essential, and do not to miss out on recording and reporting. So there is a long list which needs to be planned and done properly, and I do believe states are all geared up for this new revised NSSK as well as the new NBSU training modules, which is very, very, very needed now if we want to meet our target of our INAP targets as well as SDG targets of neonatal mortality, as well as to reduce morbidity. So moving forward, I told already that we have our professional organizations with us today, and they have been gracious enough to extend their support for these training programs. So I would request Dr. Ranjan Pejawar, President NNF, to have a few words on this, so that we know what is in their mind.
Thank you, Sumita, Ghosh, madam. Thank you. Am I audible?
Yes, sir.
Unfortunately, some technical error is there, so I can't appear on the screen. The video problem is there. I think it's common to many of us in this session. That is all right. As long as you can hear me, I am happy. I have been very impressed with not just this program, but the program and the plans for rolling out the modified NSSK and the Neonatal Stabilization Unit. I know that a lot of work has gone into this. Many midnight lamps have been burnt during the last months and years, and planning have been made. I still fondly remember being an active part of the initial NSSK program. I was the national co-coordinator in the IAP-NNF FRGM program. We had the good fortune of conducting a lot of programs. That is the basic neonatal resuscitation and afternoon and another half-day session of NSSK. They were going on well. And I think I was actively involved from 2010 to 15, probably. It is very good that people have thought that there should be some revision to that and some modifications have to be made. And I'm sure this is going to fetch even more results. Please remember, when the initial program started, the neonatal mortality rate was nearing 40s, and we are now in the 20s, or in many states less than 20. So it has had some impact, I think. However, I would request or would like to ask whether there is a impact measurement mechanism which is inbuilt in this program A. I also was very pleased to know that there will be a close monitoring of the list of trainees, where they have gone, are they actively involved in newborn care, months or years after the training. And the third part is skill retention. I know India is a vast country, healthcare is a vast task, and it's not easy to plan it as the way we want. Sometimes we have our restrictions and we have our shortcomings, but I feel that impact factor measurement and skill retention part has to be looked after very carefully if the program should be more effective. I was very proud that the two experts who are involved in today's meeting, both of them are prominent members of NNF. Dr. Sushma Nangia was the vice president last year, and Dr. Siddharth Ramji was the secretary of the NNF and is the president-elect currently. So from my side, as president of NNF, I would like to say that we will be very pleased to offer any assistance that the GOI wants from us. We are a group of nearly 10,000 people, neonatologists and pediatricians who have a special interest in newborn. We have a vast pool of NRP trained people, both basic and advanced. And we have a large group of trainers also. So may it be any state in India, if you need the help of the members of the NNF to be trainers, mentors, monitors, and handholders, please feel free to ask us, and we will respond to your request willingly and efficiently. This assurance I want to give. And at the same time, I want to commend the efforts of the Ministry of Health in constantly thinking, how do we reach the arduous or very tough goals and challenges we have set for ourselves to be attained by the end of the decade. I am sure with the zeal with you are working and we are working together, we will probably achieve it or come very close to that. So with these few words, I want to thank you for giving me an opportunity to speak here and extend the support on a personal level and NNF level to the NSSK and the Newborn Stabilization Unit training and improvement program. Thank you very much.
Thank you, Dr. Pejwal. That is very reassuring. We do need support, and with the country so as vast as ours, we need the 10,000 as experts to extend their support to us for quality, for mentoring, for monitoring and other requirements which the program might need. And now I would request Dr. Piyush Gupta, President IAP, who is also with us and extending his support to us. So can I hear a few words from you, sir? Dr. Piyush Gupta, sir.
Can you hear me?
Yes, please.
Yeah. Good afternoon, Dr. Sumita, ma'am, and all the experts, all the faculty, all the trainers, and all the people who have joined today. I am very proud to be associated with this program. I'm not talking of myself personally, but the Indian Academy of Pediatrics. As you know, it is a great moment that we have come out with the revised module of NSSK and NBSU. Let me tell you that you all know that Indian Academy of Pediatrics, with its 32,000 plus members, has been involved with the largest NRP program for last 10 years. And at present, in this NRP program, we have already incorporated the guidelines of the new NSSK. We have already made some online videos. We have converted this into an app and a website, and we have already started training in the NRP program. As of now, we have 5,000 instructors, 3,000 courses we have already conducted. We had trained more than 1,20,000 healthcare workers and spent almost 20 crore rupees, and also pledged a similar amount in the next 3 years. We have worked with the government of Kerala, UP, Haryana, and Karnataka, and currently in a MOU with the government of Madhya Pradesh. So we are totally committed to the new program or the new revised modules. And I promise and I commit on behalf of Indian Academy of Pediatrics, whatever help in terms of resources, such as manpower, trainers, funding, etc. We are all able to provide and to train. The last NSSK also, the last NRP, we had provided all our resources to train the government functionaries as well as the private partners also. And one more thing I'd like to say, especially not only about NSSK is a broad thing. So if we talk only of NRP, we would like to have one NRP, the concept of I talked with Dr. Ramji also yesterday. So it should be one nation, one NRP, whether government is doing it, whether NNF is doing it, or whether IAP is doing it. So we need to have our own NRP module, irrespective of, we may take international agencies and their recommendations, but it should be and indigenously, it has to be prepared and rolled out all across the country. Thank you, ma'am. Thank you very much for giving us this opportunity to be we are with the government at any given point of time and with continued commitment. Thank you. Thank you very much.
Thank you, Dr. Piyush Gupta. I know with your proactive stance, you are always there and you already are doing many things. I would request that we would reach out to you whenever we need assistance, especially in many states, like, which are have to do a lot of, catching up. So those states, we might need your help, and of course you continue your good work, which is being done, and always be there for any suggestions.
Thank you, ma'am. Thank you very much.
Thank you. Now, may I request Dr. Alpesh Gandhi, President Foxy, for his comments, please. We are very happy that our, for the child, the mother is also there. So please have some words on your, how your suggestions and comments, please.
Thank you, Dr. Sumita Ghosh, Madam, for this opportunity. Very good afternoon to all the experts. We at Foxy are thankful and proud to be involved in this very important program. We know that it's a mammoth exercise and the end result is very good. It is a nicely prepared training module. Foxy is the professional organization representing practitioners of obstetrics and gynecology in India, with 258 member societies and over 38,000 members spread over the length and breadth of the country, and probably one of the largest membership-based organizations of specialized professionals. Foxy encourages dissemination of knowledge, education, as well as research in the field of obstetrics and gynecology in India, and works to pilot and promote preventive and therapeutic services related to healthcare of women and children. Its primary mission is to reduce maternal and neonatal mortality and short-term and long-term morbidity in India. Foxy is closely involved with many programs of Government of India. Just to mention one program, many of our members have joined the Pradhan Mantri Surakshit Matritva Abhiyan of Government of India. The program aims to provide assured, comprehensive and quality antenatal care free of cost on 9th of every month. We are committed to bring down newborn mortality and morbidity. As a part of RMNCHAH+N strategy of the National Health Mission, newborn health continues to be of highest priority. A well-defined tiered system of newborn care at public health facilities has been scaled up across the country, and these new training modules of Navjat, Sishu, Suraksha, Karyakaram and Newborn Stabilization Unit will be helpful in capacity building of our members and staff involved in. It is the need of the hour, and we need to do a lot and to work promptly to save the stillbirth, preterm birth, perinatal asphyxia, neonatal deaths, and so many other things. Foxy is working actively for all these problems, and we are going to start very soon a registry on stillbirth. We will forward these training modules to our 258 societies to update our members. We would definitely try to find out interested members as masters trainers if they are interested, and to conduct TOTs of them. Foxy is committed to the program, and we will work collaboratively with Government of India, IAP and NNF for these training modules. Recently also, we have conducted a few programs with IAP and NNF. So we, all three associations, are working collaboratively for perinatal outcome. And we will be pleased to assist Government of India for any help across India in any states. We are there as a trainer, handholder, mentor, wherever is required. And we extend our active and wholehearted support to this initiative of Government of India. We would like to work together collaboratively as a one unit to achieve SDG goal for our country. We are once again, on behalf of Foxy, we are thankful to Government of India, Ministry of Health and Family Welfare for giving us this opportunity and for involving us actively in this program. Thank you for this opportunity. Thank you.
Thank you, Dr. Gandhi. This is, indeed a pleasure that we are all come together for this cause of newborns, because we know that the labor room strengthening, labor room capacity building of labor room staff, they are very, very vital for our perinatal outcomes, as you said. So it is very assuring that your organization is extending such collaboration to this program, and I think that is very much needed, and teamwork of our labor room staff as well as our newborn caring staff is very essential. Often, more than often, they are the same staff. So both the fields, the capacities are to be built, and they are often complement each other. Thank you very much for this. And I would request, we have with us our partners also, development partners. UNICEF is there, NIPI is there. So may I request Dr. Vivek to have your views. Are you there, Dr. Vivek?
Yes, ma'am. Thank you so much and good afternoon. So as with some of the others, I think the video link is not working, but as long as I'm audible, good afternoon to all seniors and colleagues also. So ma'am, first of all, with presence of, I see so many colleagues from the field, there is one very important point which as UNICEF, we feel that we must give, and especially the government accolades for that. We all know that COVID had brought enormous challenge to the survival and the way mothers and babies thrive. And the indirect impact was going to be much more than the direct impact. And in spite of that, last year, if we see the progress India has made in terms of ensuring its steady progress towards the INAP goal, these trainings have been revised. And one more remembrance for everyone in the state, especially that globally, every newborn action plan added the fourth milestone to be achieved by 2025, which was at least one special newborn care units in the administrative regions, which is districts. And India was one of the big countries which as of date has SNCUs in more than 80% of its districts, which has to be achieved by 2025 otherwise. And these guidelines also show the commitment of the ministry together with everyone, the partners present today and all the professional associations towards the INAP goals. So two specific points as UNICEF, ma'am, we have presence in 24 states and through 13 field offices. So I would urge our team as well as all the partners that please replicate this exercise in your respective states with all partners present there, all hands on the deck for this important cause. Another very important thing is that you would have seen in the presentation of Dr. Ghosh ma'am, Dr. Nangia and Ramji sir, we have talked about some of the new ways we can conduct trainings and their assessment that COVID has taught us. So please make maximum use of these innovations and please keep the center also informed so that, you know, if there are any good practices, these are huge numbers to be reached that can also be quickly seen if they are valid and that can be replicated in other states. So please keep the center informed, the Child Health Division, for any new innovations you are trying. And one last important point that we must remember that after SNCU's success story for India, I think this is the opportunity for next bending in the curve for newborn mortality reduction. And especially this NBSU's training will strengthen the primary health care, which we have always been talking about, strengthening of the primary healthcare system, but with good quality clinical standards. And that is where the importance is. It's not just about the numbers, but it's also about the quality of care which is being provided in these units. And we must also be ready for things like CPAP, which are going to bring about the next bending in the curve, which you will soon see the division is working on, and accolades for that also. So ma'am, we assure full cooperation with all our 24 state teams present, along with the other partners, especially professional associations. And I would end by reminding everyone that in our INAP, India has said that we must come together across the life course to make sure that every pregnancy is wanted, every birth is celebrated, and that every woman and child at the time of birth, they get the maximum opportunity to survive and thrive to their best potential. Thank you, ma'am. Back to you, please.
Thank you, Dr. Vivek. Can I now request Dr. Asfaq, please?
Thank you, ma'am.
Yeah.
Thank you. Thank you so much, ma'am. I think I just wanted to convey my special thanks to Ministry of Health and Family Welfare, especially you, ma'am. Under your guidance and leadership, we have been able to complete this activity in terms of the 20th November, we had the launch of NSSK and NBSU packages. Dr. Kapil has been kind of very supportive. We also supported the National Collaborative Center, Dr. Ramji sir, Dr. Sushma, Dr. Sadhana. I think they deserve a special mention. Besides the development partners, Dr. Deepthi is there, Dr. Renu is there, though they were at some points of time part of NIPI, but we supported the development of these packages, and that has been possible only because of their support as well, ma'am. Coming to what our role, I think that has been wonderfully delineated by you, ma'am. I think we are supporting the assessments of NBSUs, and we also supported the pilot trainings of NSSK package as well. We assure our commitment for the 5 states and Union Territory of Jammu and Kashmir in supporting the regional TOTs, the state TOTs in terms of ensuring the post-training mentoring, which you talked about, ma'am, ensuring quality and gap assessment, which we talked about, that we have already done in Odisha and other states as well. Obviously, recording and reporting and reviews, ma'am, we will assure the fullest support. Our teams are embedded within NHM. We are very fortunate that NIP is embedded within NHM in all the states. So obviously, a more responsibility on our part in terms of assuring that part as well, ma'am. And we remain committed, ma'am. I think we will assure the best possible support under your guidance and leadership, ma'am. Thank you very much.
You truly, I must thank you from my heart, bottom of my heart, that this, the release of books, the, getting into the final release would not have been possible without your help. And the team, great team who actually contributed, and they worked, they burnt midnight light lamp, finalizing it in November. Then afterwards also some corrections, some addition, alterations. So this would not have been possible without your active contribution. And so many names are there. I want to read them out that who have really contributed towards it. And I must, some of them, and I must say that the team which was with me and before me, because I came very recently, the actions were on long before that, but I have this, passion so that I finalized it. So I would say a few names, and there are many. I would say that our past commissioner, Dr. Khera, Dr. Pravakar, Dr. Harish Kumar, Dr. Ashok Devarari, and our child health team is here, Dr. Vivek, Dr. Renu, Dr. Dipti, and Dr. Vishal. So many of them are there, and really it was done when it was finalization was being done. Literally we had to, the whole team were up all night to finalize it and give it the final shape. Thank you very much, Dr. Sadhana Mehta. And I am sorry if I missed out any name, but many were there with us, and it would not have been possible without everyone's very committed and sincere contribution. So there are many questions now, and our state team is here. So they are our real strength, because without them, nothing, however much we can talk, however, presentations are made, nothing will realize actually. So many questions are there about the NPCCs going on. So regarding the budget lines, regarding the codes, FMR codes, where to enter them, how much. So with this, I would request. So I would say that the NPCCs are on. So for NBSU, we have several heads, like capacity building, we have regular review meeting, we have then data entry also for high load facilities we have. So these are the areas. And for NSSK, again, we have for training, capacity building, we have heads for having the equipments, the mannequins, having the logistics. All these heads are there. So I would request that all the states, they adequately reflect their requirements, do the proper gap analysis, and adequately reflect it in the PIPs. Many states we have done where, because they did not know the emphasis which is being given, especially to NBSU, which is a new thing we want to strengthen, as well as our SNCUs. So that part, please look into our FMR codes, and please adequately project your requirements. And I would say that if the chance has been missed, some of the NPCCs are already over. So I would request that if there is a scope in post NPCC, you please send even at the cost of having some other programs, if you can alter that. And also I would request that if that bus is also missed, the supplementary PIPs will be there. This is the right time. We should do the exercise of gap assessment and then do the budgeting. So I will again tell you the operational costs are there for NBSUs like SNCUs also. Then training of trainers is there, data is there, NBSU equipments are there, infrastructure is there. So these are the various heads for NBSU training, which you may be wanting to know. So these, please see that they are adequately budgeted. So like now this we come to the conclusion now. Today it was a wonderful fruitful consultation and meeting which we had today with all participation of all of you. I would like to say my sincere thanks first to JS ma'am. She's the force behind, and she's the guiding force behind, and she's very, very ready to accept any new things, any any ideas we promote to her. Thank you, ma'am, very much for chairing this session that has given a real impetus and motivated all of us. I request the mission directors and the teams of NHM who attended this meeting. I am very thankful to the experts, Dr. Ramji, Dr. Sushma Nangia, Dr. Sadhana Mehta, and all our expert teams who prepared and who presented and explained in such great detail the importance of these programs, these trainings, the various detailed nitty-gritties, and what should be the focus areas in this to improve the quality as well as the coverage of the training. I would request the state child health nodal officers to really look into it and to take the agenda forward, because without their help it will not be possible. And you are all there. I can see from the participant list. So please see what is the requirement of your state. Then find the gaps and find how to fill them and how to plan well. That is again and again being told that how you will take this trainings forward. Please plan well. District officials are also here. Thank you for your time and taking the agenda forward, your commitments for that. We have master trainers who are already there for NSSK as well as FBNC training modules. So thank you for thank you all for being there, and also expect that you will the new trainings also you will take forward. We have representative from various training institutes. Thank you all for there, and again we bank heavily on your active involvement in the trainings. The doctors, nursing staff of many of our facilities are here. Thank you all. Special thanks to the professional body representatives, Dr. Ranjan, Dr. Piyush, Dr. Alpesh Gandhi for being there. Our development partners, Dr. Deepti is there, WHO supporting us all through and very much a part of our own team. Dr. Vivek, Dr. Asfaq, Dr. Renu, we have from Save the Child Children, USAID, and all other DPs who have joined today this morning. Thank you all. They are from all levels, national, state, and district level. I request your collaboration and your active involvement in rolling out these trainings effectively and with quality. We have NCC coordinators, Dr. Sadhana Mehta, RCC focal persons, WHO IT team. I'm very thankful for organizing this, and this is such a big event that has occurred. I think how many participants? 1,400. 2,000 participants. Well, this is the thing well begun is I can say is half done. So my child health team members are there with us who have worked very, very hard. Dr. Kapil, Dr. Vishal is there, our regional coordinators. Thank you all for participating and joining us this virtual platform and YouTube. And I do bank on your help for making this training programs roll out a success and in a very time-bound manner. Thank you, ma'am.
Thank you, madam, for all your guidance. Now, with the permission of chair, may I close the session of today's. So, thank you. Be safe in this COVID era. So, thank you. Thanks to all.
Yeah.
Ma'am, you are muted.
One point of caution I want to say that while rolling out training, take care of yourselves, take care of the training team, take care of the trainees, because COVID is here and we must be very cautious with our COVID appropriate behaviors. It is raising its ugly head again. So please be careful and have all cautions taken while this training is planned or training is actually taking place. Thank you.
Thank
you so much. Thank you.
For
Thank you,
all the
Sumita ma'am.
people. One important message for all the participants: if they have any query related to this NBSU and NSSK, they can share us an email on newborn.mohfw@gmail.com. I have pasted this email ID many times in the chat box. You can find this email on chat box. You can also suggest us your ideas related to this implementation and rollout of this NBSU and NSSK. You can also share us all the queries on this given email ID, newborn.mohfw@gmail.com. And with the permission of chair, now I am closing this sessions. Thank you very much.